Everybody to our very first Methodist perinatal conference. So this is the first year that we've done this, and kind of taking on a unique topic approach, an important subject, informed care patient, and this is something that we see very frequently in our facility, and so something that we have a lot of expertise to share. And we're hoping that we will also learn from our guest speakers and everything today. So thank you for being here. Today's topic that we're going to work through is a generic case scenario. I say generic, this is something that we probably see or deal with almost on a monthly basis at Methodist Women's anymore, with how busy we've been and referral center. Case, but this patient probably shows up on our doorstep, like I said, any given month. We may have a case that's similar to this. So our objectives to go through today, we're going to do just kind of a brief overview of the impact of obstetric hemorrhage and provide this clinical case study discussion, experts, and focus on the impact these cases have on our patients and families, and maybe discuss some opportunities that we can identify to continue to improve our care, both clinical and non-clinical care of the patient. And then, like I said, we have a special guest that's going to share a personal experience and testimonial with us today as well. So I'd like to introduce our panel. Okay, so Kelly Barkmeyer, you get to be introduced first. She is our special guest patient who's going to share her story with us at the end of our panel discussion. Thank you for being here, Kelly. Izzy Ducey is our health practitioner and social worker from Methodist Hospital, who we lean on a lot and really appreciate everything that she does. Dr. Todd Lovegren from Perinatal Associates is one of our maternal fetal medicine colleagues who really loves critical care obstetrics. So all the day, it's probably hard, but Hanley, critical care physician, who we often get involved in these patients' care after delivery, and we really appreciate their assistance. Maya Poutre is one of our nurse cores and coordinators. I don't know, how long have you been at Methodist, Maya? Maya has a lot of experience on our high risk and labor and delivery units and has been involved in a lot of these types of cases. Melissa Strong is going to be here shortly. She's with our spiritual care and resilience team. She is a chaplain and also director of our RISE program. And then Dr. Kevin Dienema is with us from our anesthesiology group, also really critical parts of our team in caring for these patients, both intraoperatively and postoperatively. So thank you all for being here. Okay, so obstetric hemorrhage, just a quick little background. Cumulative blood loss greater than or equal to 1 liter, or blood loss accompanied by signs of hypovolemia within 24 hours. It remains the leading cause of maternal mortality worldwide, and it's a major cause for severe maternal morbidity in the United States. So as we look at these cases and review them both in our institution throughout the state, looking at maternal morbidity and mortality, this is often one of those causes that's very high on the list. Okay. As you can see in 2022, when you look at overall maternal mortality in the United States, hemorrhage moved up to the number 2 position. We're getting better at managing hypertension and taking care of patients with cardiovascular disease. And so hemorrhage has now moved into the number 2 spot, but behind mental health disorders. And some of these things are not mutually exclusive, right? So we have lots of patients that deal with very traumatic experiences related to obstetric care and hemorrhage that also suffer from mental health disorders and struggle with that post-delivery as well. So again, timing of pregnancy-related deaths, 5% of them occur on the day of delivery or within the first few days or week after delivery. And these patients really do fall into that category, that a lot of times when we are dealing with a severe outcome, it's happening in the operating room or happening within the first 24 or 48 hours after delivery. Okay. So just a little background on who our patient is today. And like I said, we see lots and lots of these patients in our system. So we have a 35-year-old, 2 babies before. advanced maternal age. She's been delivered by C-section in both of her prior pregnancies. This is a dichorionic diamniotic twin pregnancy to boot, achieved through IVF. Level 2 anatomy. She lives in rural Nebraska, and she's coming in for that anatomy and MFM consultation with our providers. She's got no complaints in the pregnancy. Everything has been going fine so far. She's got negative prenatal screening. Her AFP testing was a little bit elevated, which is expected with twins. She's married. She's got 2 young children at home, 4 and 2. And like I said, she works at one of our critical access hospitals. Okay. So she shows up for her ultrasound, and Dr. Lovegren is the MFM on that day who gets to meet this wonderful patient. And these are the ultrasound images that come through. Okay, so on our twin pregnancies, we often look at cervical length assessments. We're certainly identifying placental location. So Dr. Lovegren, I'm going to start with you. And this is really kind of open discussion. And I know that this type of question, you could probably spend an hour answering patients. How do we talk to these patients when they present? But just give us kind of your synopsis of what's going on here. How do you sit down and talk with this patient who may have about the conversation she's about to have?
Putting all this together, and thank you for everyone who's here today. Thank you for the whole panel. For those of you that know me, you know that my wife and I have been through some traumatic deliveries in our past. 3 out of our 5 kiddos were very traumatic deliveries, between losing a child, birth trauma, and other issues. And so this morning is a very important morning for me. So give me a second. Who's here to learn about this today. So patient counseling. So I give you my background about what my wife and I have been through, just so you know that really focusing on the trauma of even having these conversations is really important to me. Normally, a conversation like this takes about 45 minutes to an hour with a patient, especially if I'm meeting them for the first time and it's kind of a cold call, if you will. If I've known this patient the whole pregnancy, hopefully I've had an inkling that this was happening around 16 weeks or earlier. Sometimes this can even be caught as early as a first trimester scan when a mom's had 2 prior C-sections. So with that background, if we hop into it, I'm going to be as brief as I can here in like 10 minutes maybe or less, but I want you to understand that I'm leaving a lot of the softer language out of my conversation I would have with a patient. And generally I try to work them into how scary this conversation is. I don't just jump into the deep end like, so you could die. That how I start these conversations is, looking at your ultrasound this morning, we've got some issues on the vaginal ultrasound and on the abdominal ultrasound. One of the things that's really important when you've had prior C-sections is that we take a peek at where your placentas ended up. With 2 babies, you've got not as much uterus and a lot of placenta, so there's a good chance we're going to have some placenta end up in a place it's not supposed to be. And in your case, it looks like some of your placenta ended up in your prior scar. Development works is that when the placentas find a place to grow, it's best for them to grow, and sometimes they end up in a spot where they're not supposed to. The inside of the uterus has a lining that's a lot like a nonstick pan. And so when you have a brand new nonstick pan, you can throw as many eggs in there as you want. None of them stick. They all flip over the way they're supposed to, and they all come out and they're perfect. In this case, when you've had prior surgeries, whether it's for an infertility surgery or in this case, a couple C-sections, unfortunately, that nonstick layer starts to kind of peel off a little bit, kind of chips off. And we all know how hard it is to get those eggs off that part of the pan where the nonstick came off. Like you got to kind of chisel them off, and it leaves a little egg behind. What happens is when the uterus loses that nonstick layer, sometimes the placenta sticks to that spot. And sometimes if it really gets aggressive, the placenta can start to grow through that spot. So in this case, not only is the placenta sticking to the pan, if you will, but it's starting to grow through the pan. And that can become really dangerous for you when it comes time for delivery. What happens is babies come out, we have no problems, we can get the babies here safely, but that placenta won't come out the way it's supposed to. The uterus, and it won't let go. And the hard part is the way the body's designed and the way the placenta delivers. The placenta is made of all these interwoven muscle fibers that when it contracts down, it pinches off those blood vessels. So the reality is we actually don't need your blood to do a lot of clotting and all those things when you deliver. What we really need is that placenta to contract down, pinch off all those blood vessels and stop the bleeding. Now, what happens is when that placenta grows into that muscle and it disrupts all those muscle fibers, that uterus can't contract down and stop the bleeding the way it's supposed to. And so what happens is those blood vessels are just left open and comes from. So no matter how many medications we give you, no matter how hard we push and try to, there can be some bleeding that we can't stop. And so when we have a placenta like this, if we don't know about it, and that placenta comes out or part, a lot of moms will continue to have bleeding. That bleeding can be significant. It can become life-threatening. Thankfully, we already know about this ahead of time, and we know from the scientific literature that if we know about these things before the delivery happens, it has a dramatic impact on the outcomes. If we have you in a tertiary care center like us, with blood product and blood bank and nurses and physicians who are trained to take care of this, we can keep you safe. The chance for you to get into serious danger, the chance for us to lose a mom is extremely small related to hemorrhage if we know about it ahead of time. So the fact that you're here at 20 weeks, the fact that we caught this is a huge plus and a huge benefit to us going down the road. With what we're seeing today, this looks like what we would call a placenta accreta, meaning it's grown through the wall of the uterus, like it's gone through the nonstick pan. And what that means is that when it comes time for delivery, we're going to have to take your uterus out. Is the organ that's growing your baby and has the placenta in it. And the only time we do this is when we think we need to do this from a life-saving standpoint. We don't take this lightly. You're a young woman, you have 2 kids at home. You may want more family members. You may want more children after this. But with what we have here, this is a life-threatening issue for you. And this might be life-threatening in a month. This might be life-threatening at delivery. And so we're going to have some longer conversations about coming back to the hospital if you have any bleeding or any issues. But for right now, times I think I'm going to step out of character for a second, but when we're talking to these patients, especially if I have patients who speak English as a second language, I'll talk about the role of the uterus and that if you don't have a uterus, you can't have pregnancies afterwards. We sometimes see those miscommunications with patients. We talk to them about a hysterectomy. We see lots of nodding and they say yes a lot. And then you do their hysterectomy. We hope to be back in 2 years with another baby. And then you're now postpartum, you've done hysterectomy on a woman and she's talking about her next pregnancy. So when you have patients who speak a second language, or in some cases, one of the things we run into in Omaha is there's some large populations of folks from Guatemala who speak Mayan dialects. So we see lots of Quiche and Conjabal. They speak Spanish, but they don't speak Spanish. Spanish is their second language, Spanish very well. And so you have to be very careful with these populations, especially when you're having conversations like this. Detailed and you're very basic. Some of them don't have much beyond a 3rd or 4th grade education. So you've got to back up and use very basic words. And then a lot of times I'll spend my first visit, I'll spend half an hour to 45 minutes just talking about basic biology. So they even understand the biology that they never learned, that we take for granted that we learned in school. So kind of back to the conversation. Sometimes I don't necessarily broach the surgical and bleeding aspect a lot that first visit. I kind of let them get through the trauma of learning that they're probably going to have a hysterectomy. They're going to probably suffer a significant hemorrhage. At some point, they're probably going to end up in Omaha in our hospital leading up to delivery. Talk about it being a preterm delivery with twins, the rate of preterm birth and with like this. And we're probably talking about a 34-week delivery when she's going to present with contractions and bleeding and issues if we can get to 34 weeks. Probably have left some things out that I normally would cover, but I'll stop there for right now.
I think that's a great start. And, in our experience, and I can speak a little bit to this as well, the shell shock look on patients and it's always the question of how much of this is registering. And we often don't know until that patient calls in 2 or 3 days later, or they call the next week and say, I got to go over this again. I heard the first 20 minutes or 10 minutes of what you said, and the rest of it was gone after that. And so offering that support, and I know Dr. Lovgren, he does a great job of that. He, in fact, I know often schedules follow-up phone calls within 2 to 3 days to go over the diagnosis again and offer the patient and their family some opportunity to go through that. So thank you, Todd. Okay, so our patient kicks into ongoing ultrasound surveillance. with Dr. Lovegren, and she's still living at home, still working, taking care of her family, coming to Omaha for visits, and we're seeing her every couple of weeks to watch her cervical lengths, monitoring the baby's growth like we would in twins. And the patient then presents to her local hospital at 28 weeks with an episode of bleeding. We've counseled her, we've talked to her, any bleeding, you have to present immediately. We've got to get you to Omaha. Okay, so that education's been there. So she goes to local hospital, we get a phone call. Patient's identified to have vaginal bleeding and preterm contractions. She gets sent to Omaha, and our plan is to continue with our inpatient management at this point in time. She's very, as Dr. Lovegren alluded to, very high risk for preterm delivery due to bleeding, all of those complications. So the patient comes to Methodist Women's, and she's moving in with us. Maya is our core nurse on high risk that day. Maya's got a lot of experience with patients from all over the region, understanding some of the dynamics that take place and how hard it can be. Kind of take us through from a nursing staff standpoint. Number one, you guys do a fantastic job of keeping us on task. Things that maybe we leave out, but share with us, this patient shows up. What are the conversations? What are some of the initial things that we often do when this patient shows up to the hospital?
I think you left out, this patient was probably life flighted to us. So
Probably
she's
true.
moving in with nothing but the gown she wore. Come with nothing. Family's 3 hours away. I meet. So I think it's important to keep in mind when these patients are just about one day at a time, one moment at a time. Let's see where we go. Because it's terrifying, and they've been warned to an extent. But the reality is so different when you show up at your hospital and you're bleeding, and it's usually 2 a.m. because this never happens during normal business hours. And they come in and, now they've been poked several times. They've got IVs, they've got steroid shots. People are coming at them at once. So really hard to streamline what we can, try not to make it so overwhelming, and to be very clear with expectations. You're in the right place. This is where you're safe. We talk a lot about why they can't be at home. The things that we can offer that home hospitals can't. Their blood bank just literally doesn't have enough product to, especially in this case, the babies are tiny, but it's very frightening. We try to have a lot of creature comforts on our unit, things like shampoo, toothbrushes, nail clippers, things that they can have. And it's that first day, I think they hear probably half of what we say. And then usually by about day 3, they're in tears. That's usually the time when help at home is struggling, because this mom has 2 kids at home. She worked, so she might have some part-time daycare arranged. Sometimes they don't. It's at home to help, but can't stay for long, because the family a lot of times is like, well, I got to go back to work too. Discussions have to be had about their husband. Can he stay here with them for the next possibly, what'd you say, 28 weeks now? So possibly 6 weeks. Can he take 6 weeks off and come live at the hospital with you? Usually that's not a reality. So now you've got somebody that's looking at you. It's them in the bed and the staff. And the doctors come in and round and are very supportive, and social workers and all the teams are very supportive, but it's the nurses that they're staring at. Usually day 3 and again day 10, they sort of have a meltdown. Those also happen to be the days with depression screenings. But it's a lot of support on how do you live in the same 4 walls. And all their friends come and visit and say, I would love to be on bed rest and doing nothing. So awesome. You don't have to do anything. And they're like, yeah, I can't leave this building. We do let our patients go once they're stable and not bleeding, sort of get up and walk around the hospital. They can go sit outside. We encourage them to go have their coffee by the fake fireplace in the cafeteria. Them are able to work from the hospital. So there's a whole staff in the clinic that supports getting the paperwork done and signed off so that if they do work, they can from their hospital bed. Our patients that do the best have a daily routine. They get up in the morning, they get dressed, get out of the bed, do work, do whatever, do crafts, do puzzles. We have a lot of that on the unit too. But kind of feeling real while still literally living Groundhog Day, because it's the same thing every day until it's not. And I think that's the other piece that's terrifying. It's all fine until it's not. And so there's a lot of discussion about, doesn't matter. We're here 24/7. When it's not, it's not, but we can't live our life worrying about when it's not. So the NICU comes and talks to them, and there's just a lot of reassurance. And I think there's a lot of pieces that we do a very good job of remembering: the family, the friends, the kids at home. Social work, helps with what we can with that you don't think about when they land in here. The first thought is, oh, they're an accreta and it's all the medical things. And it's like, yeah, except they are moving in. And they are now going to literally live with us for hopefully 6 weeks. But that comes with its own bag of, situations. And like for her, then she's going to use 6 weeks of maternity leave in the hospital with us. Discussing, how do you do that? How do you navigate that? What does that look like? Do you go back to work right after you have the baby and take the rest when they come home from the NICU? It's those discussions, and we serve as a sounding board just as much as we do a medical nurse. There's a lot of mental health care that goes, getting behavioral health. Our chaplains come in and check in with our patients, and a lot of times it's not even for chaplain services. It's someone to talk to.
Yeah.
Sit and have an hour discussion about the weather. But it's somebody to talk to and kind of just get through things. We let them bring in food from outside. They get really tired of eating our food, even though it's really good. They all say that. But I'm tired of, sometimes you just wanted mom's meatloaf. So it's a lot of support. Every time we start all over things. So, I think I'll remember it's the 6 weeks before that and getting them ready.
You get to keep the microphone for a minute.
Ooh.
Okay. Thank you, Maya. I think it's interesting as providers, we talk about making the rounds, and I think get this inflated idea of how important we are. And what we do on high risk, the role is relatively limited until things really happen. And you can always tell the patients that have kind of adapted. You can tell the patients that have accepted kind of what's going on, just based on walking into the room. And I've always thought that's amazing. You walk in and she's got her scents on the wall, and there's flowers, and it looks like an apartment. And to Maya's point, a few days, sometimes for some patients it takes a week or two, but when you walk in as a provider and you see that, you say, okay, we're moving into that next phase. We're in a better space. Mom's accepted. She's understanding how important it is to be here. But you can just almost feel it. You can feel it, you can smell it when you walk in the room when they've accepted that. I think the other thing, this just kind of outlines the importance of our nurses. They wear so many hats. We think about, they're starting IVs and they're doing the baby monitoring and they're telling us when we don't have the right orders in or if we need an order for that. But really, I can tell you a lot of the phone calls I get are advocating on patients' behalf. Can the patient go for a wheelchair ride to our garden outside? Can we work on these other aspects of the non-clinical care to help this patient and her family? Having a baby shower, right? I'm hosting a baby shower down in the cafeteria. And I also want to give a plug to our hospital foundation that is extremely generous in helping these families will travel to come visit, bringing the kids in on the weekend so that they can see their mom. I mean, we've had patients that dad would bring kids up to the hospital so the girls could get their hair done before school, right? Because he couldn't do ponytails.
Thing they figured out.
Yeah.
She waited every morning to shower, and he would drop the school age one off and then bring the little ones up, and they would literally do their morning routine. She would have breakfast ready for them, and she could be a mom. And she said, she's like, I get to feel like a mom, and this is the only time. But yeah, they came up and every morning, took a shower, got dressed, had breakfast with mom. It was amazing.
Yeah.
They lived 3 minutes away.
That's away, but
little different. Our patient's now admitted. We've talked her into the idea that it's a good thing to be in her new apartment for days, weeks. Initial bleeding stops, contractions subside. She's placed in our unit. We start rallying all of our troops, right? These are patients that we want everybody to know is in our hospital. Everything's great until the minute that it's not. So notifying anesthesia providers, having our NICU docs come and talk with our patients about expectations, what it means to have a baby in the NICU, making sure any provider who's going to be an OB provider, laborist, MFM knows, hey, this patient's here, things could happen at any moment. So lots and lots of planning goes into place, and then just diligence, staying on top of that, making sure that people are aware that we have this patient. Okay, so 32 weeks rolls around. She made it a month. In the morning, 6 a.m. At 5 or 6. It's either we're putting moms on the monitor and we see changes in the baby's heart rate pattern, or they wake up and they notice that there's blood, or go to the bathroom and they're bleeding. So those 6 a.m. phone calls, I always get just a little chill up my spine when the high risk core calls me at 6:15, because it usually means something's happening before rounds that's unexpected or unplanned. She has an episode of bleeding. She's contracting regularly and she feels them. Babies look fine, but she's continuing to bleed, and the quick decision to deliver is made. So Maya or Dr. Lovegren, what happens in that moment? How quick do things start to take place? Who gets called? How do we handle that?
have to run. If we're running, a lot of those things happen at the same time. With babies that are reassuring, hopefully we have at least a little moment of time to, usually these patients have one, if not two IVs at all times, for sure one, but start a second IV anesthesia. Our teams and our process is sort of designed for, unfortunately, this event. So our nurse that's been with them on high risk goes with them to the OR. And then the labor and delivery staff take over all the rest of it. But the NICU team, the blood bank, thankfully, our MFM providers are typically either in-house or very close by, so they usually can meet us up there. Our high-risk unit is on a different, you have to load up and haul down the hallway. But we do our best to keep a lot of those things up to speed so that there's not a frantic scramble. We just literally grab their chart out of the cabinet and can run. The piece that gets challenging, especially in this, is it's been a month, so we've probably sent her husband back home, and he's 3 hours away. That's where, like, we purposely send our staff with them because that's the only familiar face they have. We take the pictures, keep them on FaceTime. We hope that they drive safely to get here. But, discussing, can we wait? Can we not? What can we afford to do? And having those discussions with the patients. And that's typically where, Dr. Lovegren and those guys come in and have to decide, can we wait? Can we not? Because I can guarantee you the nurses are saying, we want to wait. But sometimes we can, sometimes we can't. So the only other thing I was going to mention, the people that are notified, our blood bank does keep a whiteboard on the wall in our lab that has these patients listed on it. Which I think is a piece a lot of people don't realize happens, but they literally have their room number up there so that when we call for the massive transfusion, they know. Of support, it's a lot of, because now you've got a mom really freaking out because the last time this happened, she got flown 3 hours from home. Now she's realizing she's going to have babies that she's not going to get to see right away, that she can't go with them to the NICU. So, you know, we can move in 10 minutes if we have to. Ideally, we wait a few hours.
Okay. Dr. Lovgren, anything to add?
We're not going to wait a few hours.
Yeah, but
The dad on the phone, and I tell him, you know what, we're not going to have you help on this surgery, so go ahead and just drive safe and get here safely. Then have be in an accident and not be able to see the kids for even longer than mom. You know, Dr. Denham will talk in a few minutes. We have a phenomenal anesthesia team, and we have a well-oiled surgical machine. We have a very experienced team, so a lot of times these surgeries take less than 2 hours, so we're able to have a spinal, not have to go to sleep and be awake when their babies are born. I think one of the major traumas that goes along with deliveries like this, when we have these types of situations, is a lot of times moms undergo a general anesthesia at most institutions, aren't awake when their babies are born, and so lose 24 hours. And that golden hour, let alone that first 24 hours, for a lot of moms is a persistent trauma forever. So I love we have so much experience in this, and we have so much comfort with what we do. Now, there are a fair number of moms that the spinals isn't going to last long enough. Her surgery is more complicated. She's going to have to go to sleep for part of it, but at least she's been awake for that birth. She's heard them cry, seen them in the warmer next to them. The NICU will bring the babies in and have her reach into the isolate and touch them for a minute. Or if they're stable enough, mom will even get to hold them for a minute before they go to the ICU. To Maya's point, the nurse that she's known probably for weeks is at her side, holding her hand, taking pictures. To Dr. Keeley's point, you see these patients adapt, and you come out to round, and these patients will be standing at the nursing station talking to the nurses, and that's when you know things are going to be okay. But no, the morning of, it's we keep these patients typed and crossed for at least 2, if not 4 units. Be typed every 3 days. They've got 1 IV, if not 2 IVs in place. Kind of happen in the background, and some of them are nuisances. Can she have an IV break today? And then
not give IV break.
Who does, and it's not him.
Within our, I'm an absolute villain when it comes to it, because love to bleed when they don't have the IV. We do try to do this at 6:15 in the morning. Is that 7 o'clock rolls around very shortly thereafter, and we're double staffed. So our NICU is double staffed, our nursing staff is double staffed, and so it's very kind of our patients to choose for these shenanigans, because I can't tell you how many times like we've been in the OR and there's 2 neonatologists and 4 NNPs, and we have more respiratory therapists and NICU nurses than we need, and being emergency like this, like you can't describe how helpful that is. It makes it easy for Dr. Keeley and I, because all we have to do is say, I need this in the operating room, and someone runs off and grabs. A lot of them are cross-trained, meaning they can work even though they might be like a floor nurse, that they've been trained in where things are stored in the operating room. And so they can run off and grab something if the surgical tech's busy handing us instruments to stop bleeding. Our staff, it's almost not even an organized process. Like most institutions have drills and things like that to get ready for these things. It's just ingrained in Methodist culture that our staff are trained for emergencies. And of all the institutions I've been at, I think we handle that better than almost anywhere I've ever. Well, we handle better than anywhere I've been. Our core nurses, it's what they do and the storms that they manage and how they manage them are unreal, and we take it for granted every day as providers. Absolutely. Without our core nurses, it'd be a disaster. So
Sure.
Our nursing staff are what make these cases go so smoothly, because as physicians, our goal is to walk in the room and just kind of shout things out randomly, and people bring them to us. And our nurses and our surgical techs and everyone else are so well trained that we actually have the ability to do that at Methodist, and it goes exactly how it's supposed to go.
Yeah, I think that's great. You can just pass it on down the line, because all of a sudden anesthesia shows up at the door. Got the daytime duty. Welcome today. So to Dr. Lovegren's point, there's options to discuss with the patient fast, right? Even if we've done a preoperative consultation with anesthesia and had all of this, now it's on, right? So we have to make the decisions, what's she stable for, what's she not stable for. And I'm going to preface this by saying, I think that you guys have one of the most challenging jobs in all of this, because not only are you walking into a situation where a patient's fearful, significant other may not be here, they're scared, and you have to try to calm them enough to have that conversation, get them to the OR, and if they're awake for surgery, yelling at you, and nurses are saying, hang this blood, and all the things going on. How do you handle that? How do you approach these cases?
This case would be a general anesthetic. She's a accreta, which means chance for a high volume blood loss and severe hemorrhage is really high. So I would assume we'd have cell saver ready to go. We would more than just 2 or 4 units of blood ready for this particular case. So depending on depending on how much hemorrhages that we anticipate, which you can't really do for sure. That is a possibility for something that would be, maybe under a couple liters of blood loss potentially, or a liter of blood loss. But if you start talking 5 liters of blood loss or something high like that, it's to a general anesthetic. You don't. The one thing about a spinal anesthetic is it's patient because they get to be awake, get to be there if their spouse is there for the delivery of the babies, and they get to have that bonding even during this traumatic event. But one of the issues with the spinal is your blood pressure goes down, your veins dilate. And so if you put on top of that having hemorrhage, it could be very difficult to maintain adequate perfusion or blood pressure for their kidneys, their brains, or in some cases their heart. So doing a spinal can be reserved, but when you start talking accretas, I think then now we're talking general anesthetic. You potentially could do a spinal anesthetic and then follow up with a general anesthetic. So if it took, if you do a lower dose or do a epidural or some other way of keeping the patient awake for at least the delivery portion. And then if we do get into enough hemorrhage, we could do a general anesthetic. So that option is available. I do that for a patient that has a very difficult airway. We deal a lot with obese patients, or if it's other tube in, you'd want to address at the start of the case before you got into things. So for this patient, we would run to the room, be alert to the patient, talk to them, ask them, did they already have breakfast? And the answer is invariably, yes, they have, which for us is disconcerting, but that's natural. That certainly happens. General anesthesia puts the patient at great risk. They're at risk for aspiration or regurgitation and aspiration, even if they haven't had food to eat. Their airways are more swollen. Pregnancy, you have your certain, we try to give them oxygen before we get them off to sleep, but even doing that, they lose their oxygen level pretty quickly. So it's their airway is number one for us, and it's best to address that concerns whatsoever, whether it's hemorrhage or if the hemorrhage issue or if it's potentially difficult. But to talk to the patient, usually they're very tearful, they're emotional. It's difficult. I mean, I talk to OB patients, whether it's placing an epidural or talking to them in emergency, they're not really listening well what's going on. And if there's support people there, they can perhaps help. And we're going. And I'm sure, and it's very difficult for them because everything moves very quickly. There's so many people. We're pushing them down the hallway fast. And then we push them or get them to the OR bed. Somber. If we do it right, we're putting oxygen masks to pre-oxygenate them. So now a mask is being placed on them that where they're only breathing oxygen. And that's, you know, it's traumatic. So there's a lot with a general anesthetic. And even with the spinal, just the natural, just the word spinal draws fear for them. And then if they haven't had a chance to process the idea that they're going to have a regional anesthetic, just the idea of a needle being in their back. I think they know that's happening, but they're never prepared. Just for our normal elective cesarean sections, talking to them about the spinal, for some of them, it's teary-eyed. So yeah, there's just a lot of anxiety all around for this patient.
Sure.
And we quickly have to decide which type of anesthetic we're going to give. And then is when I leave the room, then I quickly do as best as I can to prepare for a hemorrhage situation.
Yeah. Great. Usually involves calling even, I know if I get in this, I'm calling, you know, we do share that with patients. There's going to be an army of people coming in. And pathologists and 2 or 3 surgeons and the whole, there's going to be 20 or 30 people coming in and out of the rooms.
Oh yes, yeah. It's full of people, definitely,
Yeah.
and you need all the hands and brains available to do that.
Thank you. Okay, so we get in the OR. This is what we find. So our ultrasound findings are confirmed, and we've got a placenta accreta that's involved, and we deliver the babies safely. We start our processes for management surgically. We know that this is turning into a hysterectomy for definitive management. The patient has been type and crossed. We call for our massive transfusion, start releasing blood products. As soon as we use them, they're getting more ready. So we're staying ahead. The patient requires 6 units of packed cells, cryo, and FF to replace all the clotting factors. Surgery takes about 3 hours. So there was some involvement of the bladder. So we had to do some work on the bladder, required some evaluation like a cystoscopy afterwards. These are pretty common things. I think in our world, most of us probably are going to do a cystoscopy to assess bladder and ureteral integrity with all of these cases because they can become very involved in the pelvis and extensive. So ultimately, the best hemostasis we can. So patient's not bleeding, we get the surgical site closed, and we move our patient to the ICU. And now we call Dr. Sandley. And medical specialties that get a call from an OB or an MFM gets that same chill up their spine that I got at 6:30 in the morning that we're going to have to go deliver. Exception of they just show up, they take care of things, they're responsive, they're fantastic to work with. They're not afraid. But these patients are different, and sometimes they're different in your world. Tell us about what this is like when you get called and you may be having to move from one institution to another to come see this patient. What are the thoughts? How do you handle these?
So I think every intensivist, each of these patients kind of core memory, you know. Labor and delivery was right below our office, and we were taught when they call, run. The ship's on fire, and we most of the patient and everything, and taking care of them for a long time. We're running into the middle of the storm, and it's trying to focus. And you say we're not scared, we're scared. we hide, you know. I go into tunnel vision, you know. It's focusing on, you know, baby's taken care of now, you know, so baby's fine. When we're involved before baby's born, it's even scarier. Now I've got 2 patients, you know, that I'm taking care of. But I go into tunnel vision. It's what do I need to do right now? What do I need to access for in 6 hours? These people have gotten massive amounts of blood products. We're going into respiratory failure, pulmonary edema, and trying to manage blood pressure, and it's a flurry. So it can sometimes be a very difficult decision when they're at women's and we're looking at the resources, like between our intensivist who's covering main hospital. This person needs a lot of hands-on direct care with me at the bedside. Do I need to move them to another institution to take care? And that's not a decision that we make lightly, because we know we're separating mom from baby in that situation. We don't want to do that, but sometimes that's really for mom in that situation. I'm rambling a little bit.
Oh, that's great. So whether it's obstetric patients or not, you know, I always think it's interesting, and I've talked with some of your colleagues before, that of the patients that you take care of have no clue who you are until they wake up, right? That they come to you, they're unconscious, they had a heart attack, they had a stroke, or a mom who's intubated. How does your team, how do you handle those cases when the mom wakes up and says, what the heck happened? Or the patient wakes up and has no awareness?
And a lot of times it's the nurses who are getting questions and things. It's like, so they, I think, bear the brunt of a lot of that. These people, we see them for a very short period of time, and then we move them along. You know, it's hopefully we have a good outcome. Sometimes it's not a good outcome. Most of the ones that I remember the most are the not good outcomes, but some of them, I can think of a couple of cases right off the top of my head. It's like, we had an excellent outcome. It's great, but I don't get any follow-up from them. You know, the OBGYNs, you know, nurses, everything, they're seeing them afterwards. They're seeing them recover. You know, we've moved them along. So it's always nice to be involved, you know, afterwards. You know, we've had some patients recently that have come up to the unit and met everybody who was taking care of them when they were asleep. You know, I'm meeting them awake for the first time ever because I took care of them in the middle of the night, and, you know, they had no idea. Yeah. So those are situations where it really makes it worth it.
Sure.
You know, but it can be really hard telling them. It's like, well, this is what happened. This is what things are going to look like, you know, going forward. And we're just happy to be able to have that conversation with them in this situation. Yeah,
it's an interesting dynamic that a lot of other specialties don't see. You know, we all get to have those conversations, and you take care of people you may never talk to, right? It's fascinating. Okay, so our patient's in the ICU. Later that day, she receives a little bit more blood product. This is pretty typical. So we do our initial resuscitation, and then out inpatient require more products. She gets transferred out of the ICU on post-op day 2. She's awake. She knows what's going on. She knows what happened. And we're moving her to a lower level of care. This is all good. But
So I'm going to make one comment now. So we're in the ICU. We're stable post-op day 1, coming out of ICU post-op day 2. This is one of the moments for me that's really, sometimes it's difficult, because I think this is where providers now diverge from patients, because providers have spent the whole pregnancy worried about her. And now that she has survived her trauma, we are excited and happy when we walk in her room, and we're thrilled with our performance and how great of a job we've done. And we're just happy she's alive. And we walk in the room and she's crying, and we're like, why are you upset? A lot of times, to be honest, I have to like gear myself down when I go in to see these patients to be like, all right, I got to put myself where she's at. Got to put myself where dad's at. We're both traumatized. We're away from our kids. Don't go in smiling. And so to me, this is always a critical point, because the first 24 hours, the family is always profusely thankful for everything. Like they get through the initial trauma of the surgery. Mom makes it out of the OR. She wakes back up. People get to say hi to her again. They didn't know if they'd get to say hi to her again. They're excited about the babies. But emotionally, this is where providers now diverge from the patient, because to a little bit of a degree, we kind of wash our hands that she survived the scariest part of this. Unless something really bizarre happens, we're probably in the clear. And so for us, like the weight's kind of off our shoulders. But for the patient, a lot of times the weight has just started to settle in. And so these first couple of days post-op, I think it's always good for providers to kind of check in with themselves and realize, yeah, give yourself that pat on the back. You saved her life. You did an amazing thing, but you got to put yourself back in the patient's shoes and walk in that room and hopefully be at the same level the patient is emotionally and where they're at in their trauma.
Sure. Thank you. That's a great point. Okay. Izzy. We call before now, but now all this, and us docs are like, where to go? I don't know where to turn. And they turn to you. Babies in the NICU, all of the same struggles that we've been dealing with, and now is dealing with the weight of all of this. And in a matter of days, we're going to send her back into the world and say, good luck. How do you see your role? How do you approach these patient scenarios, particularly after delivery, whether it gets identified through the NICU, by moms that are struggling and maybe need assistance, or through our surface? How do you approach that?
Yeah, hi. So many familiar faces here. We would definitely be meeting with the patient while they're on high risk and trying to prepare them as much as we can, talking about resources on how to get their families to be able to come visit them, and what that is going to look like when the babes are in the NICU. So hopefully we kind of have a tentative plan on what we want to do for lodging, whether or not that's working with Ronald McDonald House, which is a great resource for us, or helping them with transportation to get to and from the NICU. So we've mentioned before, we have a really great foundation program, and they really trust our social work opinion. So we lean on them a lot for gas vouchers, transportation, and just a lot of ways that we can be supportive. We've probably also been trying to prepare them to be ready for the babies. What are they going to need? What are their financial situations looking like? What for them, and help out with a lot of those things. A big factor is we're working on their mental health. So meeting with these patients, we usually build a really good rapport. Our high risk patients that come in a lot, we tend to build great relationships. So sometimes as a social worker, you're feeling like there's not much you can do, and they have so much going on and so much to process. So like we're talking about, just sitting with them for periods of time and just talking and giving them some distraction and building that rapport, so they have a safe place that they feel like they can reach out and talk about things and talk about all their emotions that are going to come up, because they have a lot to process. They have a lot to process when they're in high risk, and then even more to process with their delivery. So as we all know, trauma is in the eye of the beholder. So as soon as we hear from the nurses that they're feeling good and up to talking with social workers, we're going to get back in there and ask questions. How do you feel about your delivery? To health, what can we do? We also partner with Fremont. We've done this recently. It's a great resource, and I hope we continue to grow with them. But we have the option of getting them to see therapists in our building in the MOB. So they work with us really great to partner, because a lot of these NICU moms, I mean, it depends. They have kids at home, NICU, but a lot of times they're not going to want to go to else. They're going to want to be in the NICU. So these are their kiddos at home. So having that within the facility that they can just pop over really quick is amazing for them. You know, just again, kind of working with them with their other kiddos. Some come up daily, which is a lot, but we support that. Some of them want to come up on the weekends. So again, meeting them where they're at and what they need, and just trying to be supportive however we can. But we really tend to bond and connect. You know, you nurses do as well with these patients that are there for a long time. And I think just that rapport and that connection goes a long way with these patients. It's almost like little bits of therapeutic moments that they can bring mood, and they feel like it. So again, talking to them, meeting them where they're at, making referrals and providing resources.
Great. Thank you.
one thing that I think you didn't take credit for that we've changed in our hospital, our high risk patients are seen by the same social worker that's going to see them in the NICU.
Yep.
And come out of the ICU, they have a familiar face. And when their baby's in the NICU and they're following up for months, because these 28 weekers are going to be with us for weeks, it's the same face. So again, I think it's one of those things that often gets overlooked, but it can make a huge difference when the social worker that comes in after you've had your baby and come back from Methodist Maine and all of these things is the same face you've already seen.
It's a great point. So you're going to get a question in a little bit, but I'm the moment here because I want Kelly to be able to come up and share with us. So to reintroduce Kelly Barkmeyer, who experienced something very similar to this. Do you prefer this, Mike? Is that okay? Is that okay? All right.
Absolutely. Thanks for having me. First, I'd like to say, just sitting there, full changes from when I had. Thank you for all of that.
Yep.
Yeah. Okay. This is our first picture together as a family of 6. It was Easter of 2011. At this point, I thought everything was going to be okay. Primarily because it had been in the past. I'm a faith-filled woman and had had many prayers answered. My Hannah was my 4th baby. And unfortunately, my 3 prior pregnancies and deliveries weren't easy as well. My oldest daughter, Lily, was born 9 days late and never got to hold her because they couldn't get my bleeding stopped. They did. I'm still here, right? Then I had my David. My water broke at 29 weeks. I literally thought my bladder had stopped working because your water is not supposed to break at 29 weeks. I was on total bed rest at the hospital for 2 more weeks. We were blessed to keep him cooking. And then had another emergency C-section breech. Then I had my emigres. High risk because I had had a full-term delivery and then an unexplained premature delivery. So pregnancy went great until 33 weeks, and then I started having contractions. They were able to get my contractions stopped, but then water broke at 34 weeks. You can imagine my surprise when my OB said I was having a baby, I wasn't going on bed rest again. Okay. When I became pregnant with Hannah, it was recommended I go to a specialist, perinatologist. Actually gave me comfort that I had a specialist watching over my care. It also introduced quite a few new terms. Early on about placenta previa, and knowing that our prayer had to go to that placenta's migration. Unfortunately, that didn't occur, which I knew that put me at high risk for having placenta accreta. We joke that my Hannah has more pictures in utero. It's combined after they were. At 20 weeks, my OB appointment indicated that I had a shortening of my cervix, which put me on partial bed rest. I was able to still drive kids to and from school, but it did get me out of a lot of chores, bless my husband. At 25 weeks, I started having contractions. Went in for my appointment and learned yet another term, fetal fibronectin test. It was positive. This is when some of the fear started to set in. Upon my research, I realized that more than likely, I was going to have my baby in 1 to 2 weeks. Again, praise God for prayer. That didn't happen. I did go on total bed rest. Luckily, I was really close to the hospital, so I was on bed rest at home. This gave me time to prepare. There was a list on the refrigerator My perinatalogist had done a great job of explaining everything. And so he said, more than likely you'd have a bleed, which would send you to the hospital. So I had a list on the refrigerator because I had 3 kids at home of all times of day, who would be the babysitter, who would be the driver. At 31 weeks, I woke up to use the bathroom middle of the night, yes, and I was bleeding. We even remembered to place the tarp on my seat so we wouldn't get blood in the car. The doctor to the hospital. I got into onto the labor and delivery floor. My hemoglobin was checked often. I was quite impressed. This was 14 years ago, guys. I was quite impressed with the like little ear thing and the radio pieces, and I heard people talking, which reassured me because I knew the OR was ready. A few hours in, again, I got up to use the restroom, and they were capturing any of the blood I lost, and there was a major clot. It was then I knew to lift up this prayer, Lord, be with us. I was rushed to the OR. I feel very blessed that my husband was able to be at Hannah's birth. I'll never forget her strong cry, indicating knowing that she was okay. I then did ask my husband, am I losing a lot of blood? His response, I don't know what a lot of blood is. The fact that he did not want to leave my side, we had established a previous preemie protocol where he went to the NICU and then met me back in recovery. He didn't want to leave. Allowed me to realize that it was a lot of blood. He left. I knew I was fighting for my life. The anesthesiologist was actually one of my favorite people in the room. And I remember looking at him. I'll never forget his blue eyes. And I plead, please help me. I'm really sick. After that, all you know what broke loose. The timeline is a little tricky here. To be honest, I just have kind of a few vivid memories. One was I know that the perinatologist there had asked for the arrival time of a certain doctor. And I thought, well, crumb, this is really serious. That's the big. Also, I recall when the anesthesiologist had said that he could not get my blood pressure and he asked for a leg. He was directly told, do you see what's going on down here? You're not getting a leg. I also remember the perinatologist at one very, very chaotic moment. I could feel my anxiety, everybody else's anxiety. And she just said, stop. Everyone stopped moving. There was no noise. There was peace in the room. And she said, we are not losing this mom. I really wish I could have given her a high five. I had the feeling of fighting floating up. Again, I knew I was fighting for my life. I was so tired. I couldn't fight anymore. Part of my recovery, I'm type A, if you can't tell. Part of my recovery was meeting with my perinatologist after I had ordered all of my charts. I mean, they printed it. It was back that old. And she met with me and we went through it. And in sharing my story, I learned, like I did not code, anything like that. There were several times I didn't have a blood pressure. But at one moment during the surgery, she had to apply manual pressure to my aorta to keep all of the blood that they were giving me from emptying out. Once I stopped fighting, I had a lovely time. Met with 3 friends, a grandma, and an aunt who had previously passed away. For being in your comfiest sweatpants with your best friends, best couch, all peace, no pain, no burdens. That's what I felt. Then I had my friend Anne say I had to go back. I was not happy. I argued with her. I didn't want to go back. Also a part of my recovery, simply because I had a lot of guilt and shame because I would have chosen to leave my. When the Lord sent my 6-year-old Lily. Looking back, I realized that she would have been my only child that would have really remembered me. So he knew what he was doing. First, I stabilized. 5 is my lucky number. Via my chart review, my eye stabilized. There was a group of older moms at my church and parish who had gathered together to say a rosary for me. Okay, so I lived. Of Hannah and I in the ICU. Grateful for whoever made it happen, but they were able to bring Hannah up to me. I don't remember this, but we do have video, and I have such pride because whenever she cried or her alarms went off, I would rock her. I also, as I recovered, became a busy bee. I requested pen and paper and was bossing people from. Fun fact, my handwriting was terrible until the priest arrived. I got all the better with him. So, God bless my poor husband. He had finally gone off and awoke to the nurses bringing in a breast pump. Since the nurses that by this point I had already been pumping for my previous NICU babies, Wayne directly said, "Please ask the doctor or myself, not the crazy lady on the vent." Again, despite a few bumps in the road, I had an ileus and had C. diff. I made a remarkable recovery physically. I was motivated to improve. I would walk either out in the halls and then in my room after C. diff. I knew I had to get better for my family. Looking back, already I was having trouble sleeping. Hannah also made remarkable recovery, typical preemie roller coaster, which we were well versed in. Unfortunately, at 5 weeks, she had to be transferred to the Children's Hospital for a surgery. But she did well and was able to get home. I truly believed when she was home, everything would get better because I always had. Once I had all my kids home, but it didn't. It got to the point where I feared going to sleep. I had to have my husband tuck me in. I would clutch my rosary and I would fall asleep. The human body is so amazing. My body would literally go cold to touch as I was placed back into the OR. At this point, my energy was fading and I had no joy. I asked myself, why had I survived if I was going to be like this? I had friends say, focus on the positive. You survived. Your baby's okay. You have a beautiful family, which actually gave me more guilt because I was trying to do that. The best advice I did receive was from a good friend who said, I don't know how you're feeling. I don't know what to say. I'm just going to sit here and hold space with you. Hannah's baptism. The day of her baptism, I had such intense gratitude that we made it here that it opened the floodgates. I was on the altar crying, could not stop. It was then I realized I wasn't okay. If you've ever had this feeling, it's really scary. I began seeking help, and I learned quite quickly that Western medicine had saved my life, but they had no idea what to do with me. I was an anxious mess. I had stomach problems. They'd give me a medication. It wasn't working. They'd increase my medication. I'd have a side effect. They'd give me a medication for the side effect. I had a lot of embarrassment and guilt that I wasn't getting better. I reached out to a priest who gave me this wonderful advice. He said, "You're doing everything right. Keep trying things. If they don't work, try something else." That very same week, EMDR was recommended to me by 2 people. I probably wouldn't have taken the hint if it was only one. EMDR is eye movement desensitization and reprocessing. For me, it was life-saving. It unlocked the trauma and allowed me to process it. I saw results each session. I was able to identify my triggers and why they were triggers. The hospital where I had Hannah had a smokestack, and when it's cold, you could see the smoke. This was not safe, but when I drove by, I would close my eyes so I wouldn't have to see it. I felt my hope and energy returning. It gave me motivation to find other resources as I was still having stomach troubles. Another friend recommended a Chinese herbalist. Well, I'm Western medicine by nature, OT, and was at the point that I would try anything if it didn't harm me, and I didn't care how it worked, why it worked, but I reached out. It was amazing. I was off all of my meds within a few months. My triggers became less and less. I knew when to expect them, which also helped. I, a few years ago, had a jaw surgery and was proactive and realized that that might really affect me. And praise God, I did. The feeling of being rushed in the gurney came back, as well as the cold temperatures and the OR. I still have a sneak attack. That's what I call them every now and then. A lot of times it smells a certain soap, medical grade soap, of course. And for some reason, I know not many people like the dentist, but I really, really don't like the dentist. Helped with my emotional healing, and it also opened the doors for spiritual healing. All those prayers that I were actually being answered bigger and better. And this picture right here of the baptism is, it's messy, right? Life is messy. I really would not change one thing. This trauma has helped me address other traumas before and after. It made me who I am. My gifts. It pointed out the things I need to work on. Feelings in my trauma, the intense fear, now help me to minister to others in pain. Our worldly suffering is caused by many things, but it often elicits the same feelings or emotions. If my pain and suffering, just one person, that makes it all worth it to me. It gives it meaning. It gives it purpose. Okay. There was one more picture, so I'm just going to tell about it real quick. Supposed to be my daughter, Hannah, at her cross country race. And there is a dot of a green person, me. If you've ever been to cross country races, there are these crazy parents that run from place to kids faster.
Yeah.
In that picture, I just wanted to thank all of you, my previous providers and all future providers, for making sure that moms like me to be at those cross country meets, running, supporting their kids.
Thank you, Kelly, so much for your courage and for sharing your story. And it really, I think, brings together what we're talking about today, and how many patients go through this. Melissa Strong. I think this is kind of a good segue into just a discussion and really talking about the bridge of, how Western medicine take us and what else we need in our lives, whether that's, our faith, our spiritual care, our mental health care, all of those things. This is with our chaplain service and helps run our spirituality services, and as maybe speak a couple minutes about our RISE program and the trauma experienced by our patients oftentimes is experienced by our providers as well, by our staff, by our physicians, and there's some opportunities for help and assistance with all of that as well. So thank you, Melissa.
Well, thank you.
Yeah.
One of the things first of all, thank you for sharing your story. It's so hard every time we share it. Thank you for that courage to share. One of the things with our patients who go through this is a huge piece. And many times we think of grief only when we think about death, but grief, especially for moms, when they see those two pink lines, or when they, they imagine what it is going to be like, and this is not it. And so when that is, that dream is completely broken or changes significantly, the grief completely overwhelming. And sometimes we see that in the weeks before they deliver as high-risk moms. Sometimes it's the moments in the NICU when they realize this isn't the way it was supposed to be. I'm not supposed to go home empty-handed. And being able to be present as a chaplain to say, it's okay where you are. It's okay to feel the things that you feel. I've had patients sometimes too say, do you think it was because I slept on my right side? Or do you think it's because I had a deli sandwich yesterday when I wasn't supposed to? Things like that. And I think that the difficult part about being in the hospital is that you only have time to think, and your brain just keeps on a wheel, right? Think. And, many women overthink anyway. And I am an overthinker, right? I think part of the beauty of chaplaincy and spiritual care is can simply be present to acknowledge where people are. Most of the time, I don't know, not people delivering now, they don't know who Father Mulcahy is, but many times people think about chaplains and they immediately correlate it to religion. And that is not what chaplaincy does, right? My father was a chaplain. I tried really, really hard not to be a chaplain. But he said to me one time, he said, we are in the business of intimate strangers. We get this sacred opportunity to sit with, whether it's staff, patients, families, whomever, and share these intimate moments that even their own families aren't privy to. And are trusted with the opportunity to hear their innermost thoughts. Sometimes they can't tell anybody else. And that includes grief and even like guilt for feeling excited to go home and have a moment to themselves when their baby is in the NICU, or those kind of things. And the staff feel sometimes that way as well. Is this struggle that we have these complicated emotions in difficult circumstances, which create traumatic experiences for staff as well. And that's where, yes, we are there to care for patients, and we have to care for ourselves as well. The things that we see, the things that we experience, many staff sometimes overthink their own thoughts. I mean, how many of you guys have had a situation where you go home and you're like, blast it, I would have done it differently, right? I would have done it differently. And then that just turns in your head like the hamster again. Yeah. Does that sound familiar to anybody? But this is important for us to be able to care for ourselves and release that too. We have this. So my official title now is service leader over spiritual care and resilience. And part of one of the gifts of COVID is this focus on resilience and care for ourselves. We have to care for our own mental health as well. And so with Methodist, we have all kinds of different resources for that. And one of them is this new RISE program, which is Resilience in Stressful Events. And it is a 24/7 peer support program that was started by Johns Hopkins. It was a physician, a nurse, and a chaplain, right? Walked into a bar. No, some of their planning there, knowing them, but they now have over 170 organizations where they offer this, and now we've had over 30 calls now for RISE, where anybody can call 24/7 to say, hey, this thing sucked and I don't want to take it home with me. Can I talk to you about it? And the day that I was actually out at Women's Hospital and family asked me to come into the OR for a set of twins, and one was living and one had died. And at home with my own daughter, I was like, I wasn't fully processing what I had done that day. And so I actually called my own team and I was like, hey, do you have a second? But we all have these images or a sound or a room number that we have these memories. Once we've been in healthcare for long enough, we have these memories and we have to process them. We have to process through those traumatic memories that we have. And this includes physicians as well. I'm just going to say that out loud. RISE is for physicians as well as all the rest of the staff. FYI, just in case you didn't know. Not pointing out anybody in particular around here. No, actually, you guys do it really well at Women's Hospital. When we have a debriefing, I mean, we have 25 or 30 staff and providers. So I think the last one we have 5 providers that came. And I think it's for our own health. I jokingly say those kind of things, whether you are doing self-care, whether you're going to a debriefing, whether whether you're calling RISE, it's a wound vac for your soul, right? It sucks out a little at a time, right? And getting one manicure or taking a bubble bath isn't going to fix that. So this is something that you have to do intentionally and actively to care for yourself and process those difficult things that we've been through. And if you ever have a patient, going back to the patient side too, if you ever have a patient who is struggling through that stuff, I think it's very helpful to call a chaplain. Ask your patient if they want a chaplain, right? We don't say, hey, would you like to see a neonatologist, right? We say, hey, this is what you get because this is what I'm assessing. So if you guys are assessing that your patient is struggling with emotional or spiritual pain, go ahead and just call the chaplain and be like, hey, can somebody just pop by? Or ask the patient, would you like me to find somebody for some support for you? Because if we say, do you want to see a chaplain? They're going to be like, oh gosh, I don't want a Catholic priest. Well, guess what? I am not a Catholic priest, right? No offense to anybody who's Catholic, right? We are connected to any particular religion with an intent to proselytize. I am here to be present to help that patient or that family find hope and strength in their own belief system, whatever that may be, and their own community and work together with that. So there you go.
Thank you.
Care for patients and staff.
Call, right? Thank you. Over time, I know I got people in the back going, we got to move on. Yeah, we're cutting into break time. For questions, this was amazing. So many great stories, lots of experience shared. Catch us at the break. We're happy to answer questions. And thank you so much, Kelly, to the rest of our panel for being here and sharing your expertise.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.